Nobody knows me, as you said. Thank you. Thanks to be with Carl and Rishi. I got a surprise call in the morning. I was thinking I'll meet him here. So this is my new toy, and I always remembered when Dr. Jovanovich said, "I don't like new toys," but I'm opposite to him, even though he's my mentor. So So the 3D fantasy surgery vitrectomy for proliferative diabetic retinopathy. I don't have any financial interest. We have a big burden of diabetes, and I see Dr. Kim is going to talk on this. The main thing is 77.7 million diabetics are in India. It's an epidemic happening, and I'm going to address traction retinal detachment. And all this is a problem we face, and I think all vitreoretinal surgeons face. So I just want to say that we all know this, and in spite of the laser, the anti-VEGF, and everything, we still have a role to play as a vitreoretinal surgeon. And this is a case one, 48-year-old male with a sudden diminution of vision in both eyes. He's a diabetic since 11 years, on insulin, on poor glycemic control. His vision in both eyes is counting finger half meter. On examination, he had vitreous hemorrhage with diabetic traction retinal detachment in both eyes, and we did vitrectomy in both the eyes, one eye following the other. And this is a 23 gauge vitrectomy. You can see and thanks again to Mark Humayun, who came to India in 2004, and we introduced the micro-incision vitreous surgery together. At that time, it was a Bausch & Lomb 25 gauge, and later Class A cut, and myself did it in 23 gauge, and then now Yusuke introduced 27, and I use all of them. And you see here the aim is to clear the vitreous hemorrhage and post traction, tangential traction, and you can see fibrovascular proliferation happening from the disc to the periphery and reducing the tangential traction. And you'll see, in spite of the diathermy and everything, still after cutting, there can be ooze. And now I'm doing the diathermy, and then after diathermy, doing the vitreous cutter, but still it oozes. So I think the best is to arrest the bleeding, and I don't like to increase the intraocular pressure more often. The reason is many times we will end up seeing a pale optic disc after doing a vitrectomy. And already diabetic retinopathy affects the circulation, and then it produces the optic disc pallor. And I think we have to make sure that a raising intraocular pressure should not be the main aim to arrest bleeding. We can do the diathermy, as you see here, the bipolar diathermy, and make sure you remove every action. The idea is, again, aim at no iatrogenic breaks during the surgery. Here, we are clearing and making sure there's no vitreous attached, and following which we do the panretinal photocoagulation. And here I'm using the retinal brush to clear the vitreous hemorrhage in the periphery. And after that, you do a panretinal photocoagulation, except the optic disc and macula. And I also sometimes use the vitreous cutter itself to do the fluid exchange. And I use a non-expansive SF6 mixture just to leave the eye, the gas for a little longer than a week, so that recurrent bleeding does not happen. Earlier, I used to face a fresh post-operative vitreous hemorrhage, and we are used to do vitreous lavage and another procedure, OPD, fluid exchange, by using a 30 gauge and 10 cc syringe. But I think after using anti-VEGF preoperatively and at the end of surgery, many times we don't see this. This is a case 2 traction retinal detachment. You can see the preoperative photograph with the fibrovascular proliferation happening, and then you do a 23 gauge vitrectomy. Again, you see remove the vitreous hemorrhage and also clear the anteroposterior traction. And I use here a proportional mode to inject the fluid using the proportional mode pattern. I use the constantly, again, no financial interest. And you can see, once I make a cleavage between the fibrovascular proliferation and the retina, I now using the cutter, and again go into the convex side of the fibrovascular proliferation and cut the membrane, and then again go between the membrane and the see, now at present using the proportional mode to push fluid between the membrane and the retina. It's a patient job because you're using unimanual, and I'll be showing you a bimanual also. But you can also use a cutter and do most of the things in traction and detachment. But you need a patience, perseverance, and persistence, and that's what is important for a diabetic traction retinal detachment. And again, you have to assess the strength of the adhesion as well as the strength of the membrane and the weak retina beneath, because that's where when you pull, there's a risk of using the forceps, there's a risk of traction. And I think that's why Carl is introducing the suction in the membrane peeling. So a similar thing is used possible here. Make a proportional mode, separate the membrane, and then again use the cutter and the suction so that you can trim from the convex side of the fibrovascular proliferation, so that you're not going towards. You can see the blood is being pushed out. It is like they suck and spit. So this is what we do with a backflush needle, and now with the this is just a brush, and you clear the surface of the hemorrhage. Sometimes if you don't clear immediately, there can be a lot of hemorrhage sticking to the retina, so then that can be a problem even in removing. And here the view is a little hazy because the surgery was prolonged, and under air completed the panretinal photocoagulation, and the patient got 6/9 vision. You can see the optic disc is pale, and maybe because of the prolonged surgery or because of the long-standing diabetic with a traction retinal detachment. But the patient was 6/9. This is a case 3, 49-year-old female with a history of diabetes. We were done a. I don't do the cataract, even though I probably did last cataract in 1984, and I think after that I've never done. And I'm happy we have a team. This is Dr. Kavita Rao, my director of the cataract and cornea services. She does the phaco and phacoemulsification with a foldable intraocular lens. And earlier she was not putting the one suture, but now I think she puts one suture, and I tell them, you do your job and get out, and I'll come in. And after that, I don't have to call them. So this is the, she's doing the phaco part, and then introducing the foldable intraocular lens. And you can see there's no glow. So my surgeons are trained to the cataract, and I actually tell them, put the lens and go. I'll be able to see through the binocular indirect ophthalmoscope or the Zeiss one, where you can see the wide angle observation system. And now you can see one suture there, and then proceeding with the 23 gauge vitrectomy. And then, so you can see there's a fibrovascular proliferation, which is hemorrhage. So use the vitrectomy to remove the, again, the anteroposterior traction, and also remove the, and you can see the fibrous tissue while having a traction combined rhegmatogenous retinal detachment. You can see a break, which I have done diathermy of the fibrous tissue as well as the diathermy where the connection was there. And to avoid bleeding, you can see that I am now using the cutter to clear the fibrous tissue from the disc and the retina. And now I'm using the cutter again to remove the traction, and then I'll do a endodrainage through the break. And then I use a perfluorocarbon liquid to stabilize up to the posterior edge of the break, and then do the fluid air exchange. So here the idea is so that all traction is released, and now I'm under the PFCL using the forceps to remove the fibrovascular adhesion. The idea is again to prevent iatrogenic break close to the optic disc, because it's a dense fibrous tissue with a dense adherence to the underlying retina. And already the combined detachment, there was a rhegmatogenous break was there, so I didn't want to expand more. So here I'm negotiating with the fibrous tissue so that the entire fibrous tissue is removed, and you can see the fibrous tissue is removed, and I'm doing the fluid air exchange endodrainage through the retinal brush, and then you can see the air getting from the anterior to the posterior, and then you will see the retina attached, and then I do a endolaser photocoagulation around that break, and then use a fluid air exchange, and then air gas exchange following that. So, and if you release all the traction, you don't have to use the silicone oil. And I want everybody to know the chapter written by Dr. Jovanovich, the use and abuse of silicone oil. And I think many times people think that you inject oil and you can solve the issues, but actually you can increase the problem. You can see the retina is flat, the optic disc region is fine, and you're now doing the laser around it. And you're doing endolaser around the retinal break, and the retina is totally reattached. And then the eye is replaced with the gas. So here, this is a old media I did archiving, and I'm using the twin light, which is a twin light introducer by Klaus Eckhart, that time made by Dot, and you make an incision, and this has an excellent endo illumination, that is the chandelier illumination, and because of this twin light, it is stable, doesn't move, and usually you will not see much shadow you will be seeing here. And only thing is to introduce this twin light so that the stiletto, what you are using, you have to use that. But if you put thing wrongly, you will not able to see. So this is a curved with your scissors designed by Jovanovic, where you are using the forceps and using the curved scissors to find the adhesion between the fibrous tissue. You saw using the cutter, I did that. And the previous one, using the cutter, I did the proportional mode. And this is the old method where you use a forceps and you use a curved scissors to release the traction. And this is what, the whole idea is to be meticulous, patient, and perseverant to prevent iatrogenic breaks. And I think I aim at zero iatrogenic break. Still, sometimes it happens. And I think in 95, I think Tijuan published 20% iatrogenic breaks. And I think Jonovich said, how can you have 20% the iatrogenic break? And I think he said, if you are careless, you will have iatrogenic break. So I think that is stuck in my mind, and I make sure I do meticulously and make sure that you don't produce any iatrogenic break. And you see the meticulous dissection, and you can remove the entire fibrous tissue, and you also make sure you clear the pre-retinal hemorrhage, which is happening following the cutting the fibrous tissue, and you can see almost the entire fibrous tissue is getting removed, and entire traction is released and no break. And this is another patient with a second surgery. You can see a very bad traction retinal attachment with a lot of sclerosed vessel, but again, you can use the forceps and then dissect the membrane. You will be seeing that again, no iatrogenic break happening, and you remove, you can segment, delaminate, and then continue to do that, and finally remove every membrane possible so that you have been clearing the whole eye, and that's how you can continue the. And then, so there are favorable preoperative prognostic factors and favorable preoperative vision factors, and unfavorable is macular detachment and combined. In India, we see most of them, and whenever I used to operate in Mexico also, I used to see that. So the 3D vitreoretinal surgery is what I enjoy now, revolutionary technology, again, no financial interest. The main thing is I sit back and operate, which I never thought I can do. I sit back like that and I do the surgery, and I have designed a Maharaja chair. So the idea is to make sure the benefit of using the 3D so that you don't go back like that in front. But I always say you should do a good exercise. It's not just for the position and for your back. And I think all of us know the difference. And yesterday I was talking to Carl that we can't justify the cost and that cost to the patient. And apart from that, it's a beautiful technology. You can see here. So Dr. Kim is going to talk this. This is my All India Ophthalmic Society. So even though I have an aggressive vitreoretinal surgeon managing traction,
Natarajan, we need you to wrap up if you could.
Yeah.
Thank you. Yeah.
Thank you. Yeah. Thank you.
Very nice.